most of the information that we get regarding a diagnosis actually comes from our subjective assessment. And that's because a lot of the diagnostic tests or physical tests for patellofemoral pain actually don't have a lot of clinical utility. One of the things you might have also seen patellofemoral pain described as is a diagnosis of exclusion. So that sort of indicates that someone comes in with anterior knee pain, you rule out all of the other potential causes, and then you're left with patellofemoral pain at the end. But I think that's a little bit misleading. What we do know is that patellofemoral pain does have a very characteristic set of signs and symptoms, and this is what you should be using to get a good understanding of what your primary hypothesis might be. Then using other tests to rule out your differential diagnoses, just as you would with any other musculoskeletal condition. So based on the consensus statement from the 2015 Patellofemoral Pain Retreat in Manchester, an expert group of researchers in patellofemoral pain came up with a set of core and additional criteria for diagnosing patellofemoral pain. So our core criteria is pain around or behind the patella that's aggravated by activities that load the patellofemoral joint. So this is generally things that involve knee flexion in weight bearing. So things like squatting, going up and down stairs, running, hopping and jumping. There are additional criteria as well. So your patient may also report crepitus, particularly with knee flexion activities. They may also be tender around their patellar facets. They may have a small effusion, so not so much a large effusion, but just a little bit of an effusion in the front of the knee. And they also may have pain related to sitting. And that's actually quite common. What we've found in our research is that most people actually do report some degree of pain or symptoms relating to sitting.